So Dr. Cohen is the Director of Nuclear Medicine and Radiation Oncology at the Lionsgate Hospital in North Vancouver. And Dr. Cohen, welcome, and thank you for taking time to share your knowledge and skills with us. I very much appreciate it.
My pleasure. I'll just start screen sharing. And hopefully you can all see my screen. So I'm going to talk about what's the latest buzzword in my specialty, Theranostics, new therapies for this century and probably the next century. It's a combination of therapy and diagnosis using the same agent for both imaging and treatment. You were just talking about PSMA, so I'm going to really be focusing to a large extent on PSMA. And what one of my colleagues described Theranostics as is the ability to see what we treat and treat what we see, which has not always been the case in medicine. So it's a nuclear technique to visualize and eliminate cancerous cells. So basically, this cartoon, if you want, shows what we try to do. We have tumor cells, which is this big gray blob at the bottom. These cells have various, what we call it in medicine, epitopes, but various receptors or surface markers or things that this cancer cell expresses that we can target with an agent. And the agent can be almost anything. It's usually a peptide, but it can be an antibody that's just targeted to that one particular receptor. It can be a DNA construct that we're currently working with here at Vancouver Prostate Center called an aptamer. So what we're trying to do is target these surface receptors, or even better yet, something that's on the surface that will then pull it into the cancer cell itself. And the nuclear part comes that we put a radioactive compound on the agent that is going to target the receptor. So, and the radioactive compound can be either for imaging or for treatment. So it's a new type of cancer therapy. In the past, we've had really just surgery, followed by radiotherapy, followed by drugs that target the cancer, chemotherapy, and the latest, which is really a major advance, immunotherapies. But we're now going on and going beyond theranostics. Surgery, the limitation of surgery is you can only cut out what you can see. If the cancer has gone beyond the site, you really can't cut out everything. So surgery is really a first-line treatment to try and get the original cancer out. Radiotherapy is very effective in some cancers, but not all. And you're blasting usually a huge area around the cancer with the radiation. So you're not just getting the cancer, you're getting a lot of cells, healthy cells that are around the cancer. And that's the same limitation for chemotherapy. These are cancer drugs, but they target all the cells. You want to target them mostly to the cancer cells, but invariably they will go to other cells. The immunotherapies is to activate the body's own defense mechanisms. And one of the concepts that we have about cancers is that the immune system starts failing and some of the cancers start expressing things that hide from the immune system. So if you can stimulate the immune system, it will target the cancers, and the body's own immune system will eliminate them. There's two problems. One is that only about 15% of cancers really respond. And the other is that when you turn on the immune system, you can target the cancers, but you can target other healthy organs as well. So that basically leaves us with what I'm going to talk about, Theranostics. So the idea is that we're going to have a targeted ligand. The ligand just means it binds to something. In this case, it's going to bind to the cancer cells. And it can be a small molecule, an antibody, anything that we can come up with that will target it. And then we have a radioactive payload. And mostly I'm going to focus on these two radioactive payloads, lutetium-177 and actinium-255. Actually, that should be 225. That looked a little odd. So that to determine that the target is present, we usually want to do an imaging study first to make sure that the cancer is there and it's expressing the target. So we can use technetium-99, I-123, or PET, F18, or the most common one now for prostate cancer is gallium-68. Just, we have different types of radiation for imaging. We have gamma rays, which are produced by nuclear decay in a radioactive compound, but behave like X-rays. So once it's produced, it's essentially an internal X-ray. Beta particles are electrons. They're produced in the nucleus. These aren't the orbital electrons that you might know from chemistry. They're a little bit more penetrating, but not as penetrating as gamma rays. And then we have alpha particles, which is where huge interest is focused.
Okay.
And they don't penetrate very much. They only go really to surface. They're stopped by aluminum foil. So in 2018, my colleague from the Peter Mac Hospital, Michael Hoffman, who's doing a lot of the main research here, showed this at the Society of Nuclear Medicine meeting. And it's very easy to understand. He color-coded cancers in red. So everything that you see that's red is prostate cancer. And he showed before and after treatment with lutetium-177, PSMA-617. And most of these patients went into complete remission. So huge excitement. The problem is that most of them didn't stay in remission. It certainly worked, but my understanding is most of these cancers recurred. So there have been a number of agents over the years targeting this. This one never caught on. It was one that we were quite hopeful of for indium pentriotide or prostacint. You may have heard of it. We never scanned with it. It really had problems. It was an antibody, and it only bound to an internal receptor for prostate-specific membrane antigen, and there is a lot of blood pool, so it never really took off. Using the same targeting agents for PSMA, and this is a compound that's overexpressed in prostate cancer. It's targeting the external projection of the PSMA through the cell membrane, the outer membrane. And there's a number of these PSMA compounds. The one that we're using currently is PSMA-11. There's an antibody that I'll talk about hopefully briefly that also targets it, but doesn't target the salivary glands as much. And these ones are been labeled with another PET emitter, and some of them have less background. They're going to be horribly expensive. So my focus is not on these. The BC Cancer Agency was using PYL as part of a clinical trial with the company that sponsored it, Progenics. So people who may have had a PSMA scan at BC Cancer probably had it with this. It's now been accepted for use in the United States. They can't use it at BC Cancer anymore because it would violate the patent protection without paying for it. So they've now switched, my understanding is, to gallium PSMA-11. So just again, another sort of visual representation of what we're doing. Here's this little bar that's the prostate-specific membrane antigen that sticks out of the prostate's cancer cell or any, and that's our target. We target it with this radioactive complex, either for imaging or for therapy. If it's for therapy, the radiation is often internalized into the cell and the tumor cell is destroyed. So this isn't new in nuclear medicine. Theranostics is again, the combination of diagnostics and therapy. This Dr. Sidlin during World War II in Montefiore Hospital in New York used radioactive iodine because the thyroid gland and thyroid cancers take up this radioactive material almost exclusively. So he'd use a tracer dose to see if the patient had spread of the cancer, which would be invisible on any of the tests at the time. And then he would use I-131 for treatment. And this is a picture of the patient with advanced thyroid cancer and then doing quite well 1 year later after treatment. And this is still used today. It was the main therapy for thyroid cancer, still is for metastatic thyroid cancer. The first therapy is surgery, but it's very common for us to treat it. At Lionsgate, where I am, we usually don't treat anything except Graves' disease, which is an over expression of normal thyroid. So it's an overactive thyroid. We treat that with radioiodine, and we refer all of the patients with metastatic thyroid cancer to Vancouver General because they have the biggest experience of doing the treatments. It's a fairly rare type of cancer. So this is the image. This is much more intense uptake in the thyroid bed than should be. All of this should not be there. The lung uptake indicates tumor. The liver uptake indicates that the thyroid cancer is producing thyroid hormone and there are receptors in the liver. This is normal bowel and this is normal urinary excretion. And 1 year later, after getting the therapeutic dose of I-131, so here in Vancouver, it would be at Vancouver General Hospital more than likely, the patient is completely disease-free. This is just salivary gland excretion, which is normal. This is stomach excretion because iodine behaves like chlorine, so there's hydrochloric acid in the stomach, and then what's made in the stomach goes into the bowel. So this is the large bowel, and some is being expressed in the urinary bladder. So all of this is normal. The cancer itself, which was in the lung and in the thyroid bed, is gone. So from there, the next interest was in Europe, primarily with a compound lutetium dotatate. It's a somatostatin labeled with lutetium-177. In 2010, so about 12 years ago, they started treating a rare neuroendocrine tumors, which overexpress somatostatin on their cell surface. This is the same cancer that killed Stephen Jobs. And he went to Europe for this. Unfortunately, he left his cancer. He was trying ballistic therapies and it had spread too far. So while he probably responded, it wasn't curative. This is a metastatic insulinoma treated with lutetium octreotate, which is now available in BC for the therapy, as is the scans for this cancer. And what you're looking at is, again, normal stomach, normal bowel, normal bladder excretion, but this liver has got a lot of little dots in it, and that is all tumor. This is after 4 months of treatment, and again, good response of the tumor in the liver to the radiotherapy, and then in 9 months, further response. So not a cure, but a very effective treatment and very few side effects from these treatments, unlike chemotherapy or some of the immunotherapies even. This is just showing a durable response, liver with a lot of holes in it, it's tumor, and then after 2 years, complete remission. There's been, unfortunately, I didn't bring any slides, but there's been a new compound that's been targeted to neuroendocrine tumors labeled with an alpha emitter. They're getting complete remissions, unbelievable responses. Unfortunately, the only thing they've published is 5 patients, but all of them had complete remissions. So they wanted to see how good this was, and what they did was look at lutetium-177, somatostatin, compared to just long-acting somatostatin, which is one of the major ways of treating it. And what you could see is patients who just had the long-acting somatostatin had, these are the patients with the, go back. These are the patients with the long-acting somatostatin showing very high mortality and significant improvement in event-free survival and long-term survival with the lutetium octreotide. So 79% reduction in risk of disease progression and death, 40-month mean progression-free survival, hazard ratio, the lower this is, the better. So very good response. And this is what we expected to see, and I'll show you the pivotal trial with the PSMA. Wasn't quite as good, but I'll show you the data. So we have the Theranostics compound. This is again at the Peter Mac in Sydney, Australia. Here's a patient who's being scanned with the PSMA gallium-68 scanning agent, really advanced prostate cancer going throughout the skeleton and lesions really everywhere. And this is the scan after getting the lutetium. Lutetium also emits gamma or X-ray, so we can actually, doesn't give quite as good pictures, but we can also scan and then do dose calculations with this compound. So the main PET compound for cancer for the last 15 years has been this one. It's a glucose compound, and most cancers overexpress glucose. Unfortunately, prostate cancer doesn't. So this is the bone scan of and most of you have probably had bone scans, of a patient with metastatic prostate cancer. And here's the corresponding FDG PET scan, and almost no expression of the glucose receptors in prostate cancer. So generally, it has not been used in prostate cancer. But PSMA just got approved for scanning in the United States about a year and a half ago, and shows normal CT, but a very clear lesion on the PSMA PET scan. So this agent is approved in the United States, but guess what? It's not approved yet in Canada. We can only give it as part of a clinical trial, whether it's at the BC Cancer Agency or the private PET center that I'll talk about at the end. So CT and MRI can't see PSMA receptors, and as I said, I doubt they ever will. CT almost certainly never will, but I have physics friends who are MRI specialists who think that it can do everything. I doubt it will be able to image these receptors, but I think in medicine, you can never say never or always. So this is the CT, doesn't show anything. And here there's nodes in the iliac chain, this area, this one area that's lighting up here. This is probably just normal bowel, the other red. So CT, it's absolutely invisible, very visible on the PSMA scans. So why can we see things that the CT and the MRI can't see? Well, CT and MRI actually have better resolution. So one of the things we now do is we actually combine our nuclear studies with poor resolution with a CT to just see where it is anatomically. So CT and MRI can resolve down to about 1 millimeter. PET is about 4 to 5 millimeters, and SPECT, which is what we tend to use for bone scanning, is probably about 8 millimeters to a sonometer. However, in terms of contrast, PET and SPECT have 1 million times, that's 1 followed by 6 zeros, more contrast than CT, and 1,000 times more contrast than MRI. And this is just showing it. Unfortunately, I think I cut it off at the bottom. PET and SPECT really don't have good spatial resolution, but MRI and CT are way up here, and PET and SPECT are way down there. And really, you don't care how well the modality can see your normal organs. What you want to know is how well can it see the cancer. So how much better is PSMA PET than CT, which is the main diagnostic agent? As was said, MRI has certain advantages. It's not probably got quite the same good spatial resolution as CT, and it takes a lot longer to get the scan done, although that is going to speed up quite substantially over the next couple of years. But when you look at these studies comparing PSMA PET to CT, 25% of men who had very high risk Gleason scores, who were staged as having no metastases and no spread outside of the prostate on CT, showed either one node or advanced metastases. So that's 1/4 of those with high risk Gleason 4+3 and higher. 70% of men with biochemical recurrence and PSA of 0.2 to 1 had detectable lesions. So the paper that was presented saying the 0.6 cutoff, I'm the first to say I don't know where the cutoff is. I think a lot of it depends on how aggressive the cancer is, and we'll probably see it at under that 0.6 that was quoted if it's aggressive, but may not see it if it's up to 1. So and the arrows just show on the PSMA scan, we always get normal excretion in the kidneys. These are the kidneys. These are the ureters. This is the urinary bladder. Normal uptake in the liver, spleen, and some bowel. And unfortunately, as we'll see, we also get normal uptake in the tear glands and in the salivary glands. Another look at it. Oh, I cut this off. So this is very low expression of PSMA. I can't remember how low because I cut it off. You could only see about 5 of them with CT, and you could see 5 times as many with PSMA. And in the other ones where it's 1 to whatever it is, 10 or something, above 10, it's almost twice as good with PSMA as with CT. And I would think it's probably very comparable with MRI. Most of the papers coming out now say even for primary staging within the prostate, to do a combined MRI and PSMA in preference to almost any other imaging test. So I knew I forgot. I put this on the following slide. So here's the PSMA PET and here's the contrast CT. 11 out of 44 with PSA levels under 0.5, 2 out of 44 for the CT, 18 out of 27 for 0.5 to 1.5, 11 out of 27 for the CT, 73 out of 79 for the PSMA scan, 50 out of 79. And as it gets higher, obviously the CT you'd think would get better, but it still misses probably about half. So the take-home message is, even if your CT is normal and your bone scan is normal, doesn't mean you don't have prostate cancer that would be detectable with a PSMA scan. So the National Comprehensive Cancer Network upgraded its guidelines for imaging prostate to include new molecular-driven strategies. This was in 2021. Additionally, the new guidelines state conventional imaging is no longer a prerequisite to PSMA PET, and that PSMA PET CT or PSMA PET MRI, there aren't a lot of PSMA PET MRIs in Canada. There's one at UBC, but it's being used for brain imaging for dopamine receptors. So really it's PSMA PET CT. And again, just showing the difference. Bone scan with a couple of lesions, the PSMA scan showing just significantly more lesions detected. So now I'll switch from using PSMA to scan, where it's now becoming essentially the first line test for cancer, if it's a advanced Gleason score cancer or if for recurrence, to the therapy. This is just showing period of chemotherapy. Usually it's docetaxel. So again, we are attaching currently lutetium-177 to a PSMA targeting agent. It's a folate compound that targets the PSMA receptor and will give off a beta particle. This can be shipped, so like gallium-68, where it has to be shipped within a few hours and imaged within a few hours. The lutetium has a almost weak half-life. It has short-range beta. There's a lot of commercial supply simply because the somatostatin for neuroendocrine tumors, this was developed for that, so the commercial production was already there. And the drug conjugate binds to PSMA, which is expressed in disease cells at something like 100 times the normal prostate cancers. Once bound, it releases an electron, an energetic beta particle that can kill the cancer cell. So this is one of the first reports, again, from Peter Mack, just showing patient with 2 cycles of lutetium PSMA and having an excellent response. Here's the tumor. These dots are tumor, and those dots have no longer seen after the therapy. So here's the standard way. You go on some sort of anti-testosterone. This one was an estrogen compound. The cancer, the PSA keeps climbing. Patient is then put on Docetaxel, responds, but and then is also put on a beta, which I can never pronounce, and responds quite well. Then recurs, PSA climbs again, is put on enzalutamide, responds, and then has really advanced prostate cancer, PSA of 967, first response to PSMA, and the patient here has a complete remission. That unfortunately recurs, but is given another therapy of PSMA, recurs again, and responds to the next treatment. And even though the disease is progressing, keeps responding. So this is a real game changer. And it's only the first of many game changers. So the pivotal trial was the VISION trial, which BC Cancer took part in. And I only heard anecdotes from the trial, but one of my colleagues over there who was treating patients, Dr. Wilson, Don Wilson, basically said that they had a lot of patients that they would give this compound to, and they would just get maybe not complete remission, but really substantial benefit from their symptoms. So this study concluded about a year ago. They were treated with either an androgen receptor inhibitor or Taxol, and if they had been on that, they were then put on the standard of care, excluding immunotherapy, radium-223, and other investigational drugs. And they had to have a reasonable life expectancy to get into the trial. And they were followed with PET-CT with gallium PSMA-11, but they had to have shown that they expressed it on an initial scan. Otherwise, it was pointless to treat them if this cancer had dedifferentiated and was no longer expressing PSMA. So they were either put on standard of care or standard of care and lutetium PSMA, and then they followed them every 8 weeks with CT, MRI, bone scans, and did the analysis, I think, after about a year. These are the survival curves, not as good as I would have thought, but there's a couple reasons, I think, for that. So this is the standard of care, and this is with the PSMA treatment. Not a huge benefit in survival, only about 4 months. But I'm going to give you why I think the survival is actually much better. And so the hazard ratio was 0.62 compared to 0.21, because I don't think there should be any real difference between lutetium PSMA and lutetium somatostatin. I think what happened is nobody wanted to go into the standard of care arm. They would drop out if they were told they weren't going to get the radioactive therapy. The other thing that they did in Australia that they didn't do as part of the vision trial because they wanted to get it through faster is in Australia, they had to also get an FDG scan because the FDG would pick up whether the cancer had dedifferentiated, and they would not treat those people with PSMA because they knew that the undifferentiated cells would not respond to it. So I think the response to PSMA is better than being expressed in this trial, but it's probably good enough to get the drug approved. It's still not approved in the United States or in Canada. It is approved in Australia, Germany, India, and I think Israel. This just shows that those that were on the trial had a little bit more nausea, vomiting, dry mouth, which was transient. And the Germans never reported this, but this vision trial, they had more blood response, which is not good to the radiation, although it was transient. A lot of these other things are probably really not related to the PSMA. So this is in all grades, and those that really had high grades really probably had less toxicity. So I'm going to talk about what's now still under clinical trials. The lutetium is not under clinical trials only in Canada and the United States, but we expect approval imminently in the US and probably in about 6 months to a year in Canada. We're always a bit slower. So the beta particle is penetrating. The alpha particles are really stopped by even a piece of paper, but they have about 4,000 times more energy and they don't travel as far, so that they're much more destructive and they have a much higher likelihood of killing the cancer cell than a beta particle, which might damage it, but the cancer cell might be able to repair. The other advantage is that they only go really into the cancer cells, which are these things. The betas actually have a longer range and can target more healthy tissue, but it's a double-edged sword. They can also go and kill other cancer cells that are at a distance. But they seem to be able, the alpha particles, to treat cancers that stop responding to the lutetium, the beta. So this is a patient that had extensive cancer, metastatic prostate cancer, got 3 treatments with lutetium PSMA, really not a great response, and then had 3 treatments with the actinium-225 and almost, again, a complete remission. And this image has been shown around the nuclear medicine world for repeatedly at almost every meeting for the past 3 years. They can treat metastases that are close to critical organs, like in the bone marrow, so that you don't get the same marrow toxicity, or shouldn't, from the PSMA alpha treatment, actinium-225. And there aren't a lot of alpha emitters that are available. Astatine is really difficult to get. This one, the French are using and have been getting really good results, lead-212. So you may hear more of that, but the agent that's probably going to be used the most when it becomes available is actinium-225. It's got a good half-life, it decays into 4 alpha particles, which we may be able to take advantage of. And this was one of the few trials that has been published. This guy's at the University of Heidelberg, and they've been doing most of these treatments. The Australians are now starting to do treatments with it. I don't think anybody that I know of in Canada or the United States is doing it. If you want a treatment, the best place to go is probably India. So they had 40 patients who received this treatment. They had, at the time of the treatment, a survival projection of 2 to 4 months. They received 3 cycles in 2-month intervals. 11 patients didn't complete. So out of 40, only about 30 actually completed. 5 had no response. 4 stopped because the actinium targeted with PSMA 617, it targets the salivary and tear glands, and it wipes out the salivary glands so that they can't enjoy food and they have a very dry mouth. And because these were given in advanced prostate cancer, 2 did not survive even the 8 weeks to get the therapy. However, among the 38 surviving patients, 87% had some PSMA decline, 63% had a decline of more than 50%. Tumor control lasted for an average of 9 months. 5 out of 38 patients, or 13%, had a response lasting more than 2 years. Realize these are people who had a life expectancy of 2 to 4 months. And all their previous therapies have not done as well. Now, there's a new agent, I don't know if any of you have heard about it, FAPI, fibroblast activating protein inhibitor. This is expressed on a lot of cancers, but not on the cancers, on the fibroblasts. These are tissues that form, cells that form scar tissue around the cancer cell. So the body's trying to wall off the cancer. This is the FDG scans, and this is the FAPI scans, showing that it targets most cancers almost as well as the FDG, and that now includes prostate cancer. So we think we're going to have another theranostic compound, and this one doesn't target salivary glands, so it can be labeled with lutetium and actinium. Very little's been published, nothing in prostate cancer. Only in pancreatic cancer last time I did a literature search. This is a compound I'm working with. The compound's just in clinical trials in India, and it's targeting breast and lung cancer, which is where it's going to be used first. We're hoping to be involved with the scanning and then the therapy trial here. I don't know whether it targets prostate cancer. I have hasn't been used to my knowledge, but targets just as well or better than FDG. So in Australia, which is about 10 years ahead of us, this is in Perth. The guy with the long hair is Harvey Turner, who I believe may have just retired. He's been around for years. He had this freestanding radioimmunotherapy clinic for treating PSMA. They're available in Vancouver at Initio, and they're not commercially approved in Canada, even though the scans are now approved in the United States. 2 companies are asking Health Canada for approval, but Health Canada is extremely slow at approving anything. And they are, however, because of the demand, allowing special access. But we're limited to 20 patients a month under the special access, and it has to be approved first by Health Canada, although in fairness to them, they are approving just about everything that's being submitted. Scans are ridiculously expensive, $3,200. That's because one, we don't have our own gallium generator, and the generator was only available 1 week per month, but I think we've managed to talk the Isologics, the Central Radiopharmaceutical Company for Vancouver, into making it available 2 weeks per month. If we get our own generator and we can get our own PSMA once it's approved, I think we can cut that price in half and hopefully even lower. We're trying to get the cost down, but to say that the drug companies are not helping is an understatement. And Health Canada requires a drug company to file for approval. So as I said, 2 companies, Telix, an Australian company, and Novartis, a Swiss company, are now filing for approval. Initio is working to try to find clinical trials where this PSMA may be available for free as part of a therapy clinical trial. We're having discussions with Novartis with their lutetium agent. Again, it's not approved, but we can get it as part of a clinical trial. They're not available in the USA or Canada, either compound, lutetium or actinium. Patients who need to seek treatment should travel to Australia, Germany, Israel, or if it was me, I'd probably go to India, although the Germans probably have the best experience. But the Indians are not far behind. They're way ahead of Canada. It's quite embarrassing that a third world country is so far ahead of us. It's likely to be approved now that the vision trials are available. It's been filed for FDA approval about 6 months ago. I think it'll be approved imminently. Health Canada, probably another year. And BC Medical Services will not pay for PSMA scans or therapies. You can get the scans if you're really lucky. And maybe the therapies at BC Cancer Agency, I think they probably will have about a 5-year wait once this thing is approved. And I'm the one who gets fee items. I cannot get a fee item for either the scanning agent or the therapy. I'm not even going to try. Doctors of BC is useless. I told not to do editorial in my comments, but the medical profession and the government are useless, and they will not do anything unless you guys start screaming at them. And I don't mean talking politely. I mean doing something like the truck drivers. We've now put in a brand new PET-CT initio. I'm a director. I don't read the scans there. I leave that to my colleague, Dr. Tarswell. I'm busy enough at Lionsgate reading bone scans in prostate cancer. I'll probably be more involved with therapies once Novartis agrees to let us do some of their clinical trials. And Initio's been providing PET-CT in Metro Vancouver for over. So that's my presentation. Kept within the time limits, and I'm more than happy to answer questions.